Awesome. Cool. So you wanted to chat about OB meds for the NCLEX, is that correct?
OB in general, and then just any med stuff that you can suggest.
Okay. Cool. And then where are you located? You're in Australia
Yeah,
and you're taking the NCLEX like as reciprocity to come to the US or something like that?
yeah, exactly. So I'm booked in for the 25th at the
Okay.
NCLEX,
Right
and
on.
then I'll be moving to Colorado as soon as my visa comes through. So hopefully in the next month or two.
Oh, nice. Solid choice. I mean,
Yeah, yeah.
it's not New Mexico, but it's a good set.
Yeah.
Nice, dude. Sweet. And how long have you been a nurse for?
About 8 years.
Sweet. Cool. So
So mostly ED and then military. So some primary health, some aviation, some aero retrieval stuff.
right on. What will you be doing in Colorado? Do you know yet? Or are you just coming out here first and then we'll find a job?
Yeah, hopefully I'll get at one of the big trauma EDs
Okay.
at University of Colorado or somewhere like that.
Nice. Sweet, man.
So
Cool.
yeah, that's the plan. But I've just got to get through this NCLEX exam, which is throwing me a bit.
Yeah. Will this be your first time taking it?
Yep.
Okay. And then what have you been using for studying in general?
I got this one.
Okay, right on. Yeah, I think
And
that's just in general like a good way to go for test prep in general is just getting a bank of like practice questions.
yep. Yeah, so I've just been working through those and then either get them right or I just write down the rationale and try to
Okay,
get my head around it.
sweet. Cool. Well, we can definitely go through some OB stuff. I mean, I have to admit it's not my area of expertise, but this is good for me to brush
Yeah.
up on as well. Let me see if I can share a screen here. Can you see that?
Yep.
Okay, sweet. So I guess my understanding before, which maybe was not totally accurate, was that you wanted to go over specific medications. But regardless, I think this is like a good starting point to go over
Yep.
just things in general. So I have an old pharmacology book from nursing school when I did my BSN. And I just went through the chapters on OB and just kind of made a
Mm-hmm.
list of like the medications. And then I went through and like just highlighted or made bold a couple things that I think are more high yield than the others. That like a lot of these we don't really need to know for the NCLEX.
Mm-hmm.
I mean, I guess maybe don't hold me to that. It's been quite a long time since I specifically studied for that test. There's some things that I think will commonly come up. I don't think they will likely get into like the emergent stuff that you're mostly familiar with.
Mm-hmm.
But I guess at a superficial level, we can review that just to, um, yeah, just review some basic like physiology and pathophysiology stuff, I guess.
Yep.
Um, so cool. I guess we can just like work through this list and like whatever questions we come up with along the way, then we can identify them. And then I have my textbook here.
Mm-hmm.
So if we need to reference anything, we can.
Yep.
Cool. So general things during pregnancy, I think it's like fairly high yield to talk about both like iron supplementation and folic acid. Both of them
Mm-hmm.
would be like included in like your standard prenatal vitamin. The idea behind the ferrous sulfate is that you can get anemia with pregnancy if you're not supplementing, just because you're using a lot of the body's resources to build another human inside of mom.
Mm-hmm.
And that I think increases throughout pregnancy. So like the most need for iron supplementation would be in the third trimester prior to delivery, when you get like the most increase in size. And that sort of checks out like, the big thing in the body that iron is going to is um, blood volume. And with the growth in the third trimester, that aligns well with that. So I think that one's pretty easy to understand. Um, and then with folic acid, the concern there is that you can have um, problems with like fetal development. So I think spina bifida is the most common complication that comes up in the testing environment. Uh,
Mm-hmm.
so that would be the one to keep an eye on. Like if there were a test question about it, like why are we supplementing with folic acid during pregnancy? That's like the thing they would ask about. Whereas for iron supplementation, it's likely going to be for anemias. Cool.
Yep.
Sweet. Any questions on those ones?
No, they're pretty straightforward.
Okay. Yeah, the other ones here are just mentioning things about like different treatments for nausea and vomiting, just like symptoms of being pregnant in general. I don't think
Mm-hmm.
you would get asked about any of these medications like specifically for OB, but like the NCLEX can test you on all kinds of medications. And the things that they tend to focus on are a little different than what we focus on in the pre-hospital setting or in the emergency setting.
Mm.
That was like one thing that I struggled with in nursing school is that I wanted to learn like the indication and the dose, right? But in
Yeah.
on the nursing side, it's not really the priority because you can always reference those things that are going to have a direct order. Um, so they're more looking for you to be familiar with like what the medication is used for and concerns with like with delivery. So like,
Mm.
are you taking it with food or
Yeah.
without, or are there concerns with the medications? You don't necessarily have to know the specifics. You just need to know that those are things to reference. Uh,
Yeah, and that's I'm struggling with that a bit.
yeah, I mean that was really tough for me. I remember like the worst grade I got in nursing school when I first went through was in pharmacology because I mean I had all my doses memorized because I thought that's what we needed to memorize, but that was
Mm-hmm.
not the case.
Yep.
Um, so I don't think any of these are particularly high yield. Um, I'm just looking through this list here. Yeah, yeah, I wouldn't worry about the specifics on these other than just knowing that like if you see any of these, then the likely reason is going to be for nausea.
Mm-hmm.
Um, yeah, I mean if you have tons of time and you want to look into like the specifics to any of these, I think I don't know, you maybe could, but I wouldn't worry about getting into the details on any of this stuff.
Yep.
Same thing with these ones that are available over the counter. Um, the brand names here may be different than what you're familiar with, but I got the generic ones there as well.
Mm-hmm.
Um, yeah, I wouldn't focus too much on those symptoms. The general ones would be your iron supplementation and then your folic acid. Um, I do think, however, scrolling down here, that your tocolytics are always testable, both in
Mm-hmm.
the emergency setting, like whenever you're getting into specific certifications, but also in for the NCLEX. So knowing that the two primary tocolytics that come up on the nursing side would be terbutaline and mag sulfate. Um, I don't think you need to know like the specific doses for those, um, but knowing like the drug classes is likely something that could be tested. Um, and they're listed there for you. And I can send this document to you afterwards. You don't have to write
Oh,
it.
yeah,
With I'm happy to
that'd
just
be
shoot it to
great.
you by email. Um, so yeah, I would think it's worth knowing both of those. Um, the concerns with those medications. So um, the main one that may get testable that like seems to always come up is if you're giving mag sulfate that can cause respiratory depression. The normal way everyone says that we're supposed to like assess for progression towards respiratory depression would be checking deep tendon reflexes. In practice, like at least in the transport and emergency setting, we don't often do that. We have better tools to observe that, like end-tidal CO2 monitoring, like waveform capnography. Um,
Mm-hmm.
but the fix would be if you gave too much mag or gave it too fast and had problems, so you had a patient who stopped breathing, you could fix that by giving calcium. So calcium gluconate or calcium chloride. So that's worth knowing as well. And then because of that, anytime we're giving magnesium, we want to give it slowly. So like in a non-emergent setting, like we're talking about in OB, we're going to give that like fastest over 10 minutes, but likely over 20 or 30 minutes.
Yep.
Cool. The next one here is, and the order of these is just the way they happen to be presented in the book. There's nothing special about this order. Um,
Mm-hmm.
for surfactant development in the fetus. So if you have a baby who's looking to be born preterm, the concern is that the lungs may not be fully developed. So the primary treatment for that would be betamethasone or celestone. So that's something that frequently comes up on tests. You'll sometimes see, like in a couple of the books I have lying around here, you'll see that dexamethasone or decadron is like mentioned as an alternative. Um,
Mm-hmm.
but I don't know. I don't work in OB, so I don't know how frequently that is used. But I have seen on tests before that the betamethasone question comes up frequently. Um, so yeah, that's something to keep in mind.
Yep.
Um, and then the next one that I think is particularly high yield, it will be like the complications. And it was listed in the textbook I have under preeclampsia.
Hmm.
But I think it's worth reviewing in general, like the whole spectrum from pregnancy-induced hypertension to preeclampsia and potentially eclampsia, and then to HELP syndrome. So that's something you haven't reviewed in a while. I would definitely just kind of brush up on that. Um, but I guess if we start at the beginning, so pregnancy-induced hypertension is, basically as it sounds. So somebody's at baseline before they get pregnant, they have a blood pressure what would be considered normal, and then after they get pregnant, they develop hypertension, and that typically will resolve after delivery of the baby. But the concern is that if mom is markedly or not tachycardic, hypertensive while she's carrying the baby, that can put us at higher risk for certain complications. So we want to treat that during pregnancy. I pulled up a paper on that just for my own reference to review, but I can send that to you as well,
Hmm.
about this general progression for pregnancy-induced hypertension, all the different agents we use. Um, the next step, I guess, in the progression would be preeclampsia, where we're worried about the mom going into eclampsia or having seizures, and that's where these medications that are listed here come into play. Um, so if we're on the hypertensive side, but we're like in this preeclampsia realm and we acutely want to drop blood pressure, um, we often go to these two, hydralazine or labetalol. Those ones are in bold. And it kind of depends on like what protocols you're working under or what reference you're looking at, which is first line, which is second. But those two are commonly used for preeclampsia. Um, you sometimes will see magnesium given, like for somebody who is quite prone to having seizures to going into eclampsia. But it's
Hmm.
definitely the treatment of choice when we actually are eclamptic. So once the mom is having seizures, we want to give magnesium first. Um, so I don't think that the NCLEX would ask you like specifics about any of these. I don't think they would um, test you on specific doses or um, like specific drug types for these, but I do think it's fair game for them to ask you about which of these potentially is a treatment for the preeclamptic patient or for the eclamptic
Yep.
patient. Um, and then on the far end of the spectrum would be HELP syndrome. So that's when you have elevated liver enzymes and low platelets, and those would be the two testable things. So like maybe you would have a question, I don't know, like your patient presents with she's undergoing treatment for pregnancy-induced hypertension. Um, Routine lab work shows either or both um, elevated LFTs or low platelets. What's going on with the patient? I don't think they would specifically ask you about treatments, but I think just being able to identify that that's what's going on
Hmm.
be something that might come up. Um, the next thing I have on my list here, which is about induction of labor. I don't think any of this stuff is particularly high yield, but I think it's worth just like being familiar with these medications and knowing what they're used for. Um, but aside from that, the only one that you may see is oxytocin with like postpartum hemorrhage or something like that. Um, but in general, like at the entry level for nurses, we're not. This is stuff you're going to learn when you like if you go into OB. Um,
Hmm.
but I guess it is it is fair game for testing, at least at the superficial level. Um,
Yep.
so the next one here is there's a section in my book about postpartum promotion of bowel function. And these are all things that I think are testable, not specifically for OB, but just in general. They're medications that get used a lot in the hospital setting for inpatient nursing. So just being familiar with your stool softeners um, and your laxatives, I think makes sense going into the NCLEX. I wouldn't spend a lot of time. I think just like knowing the names and knowing that they are like stool softeners and laxatives. I don't even think you need to be able to differentiate which ones are stool softeners and which ones are laxatives. Just in general, those are ones to promote bowel function or to avoid constipation, I think are worth knowing. And then the next one here that I think maybe is worth reviewing as well is things that are given after birth, given to the neonate after birth. I guess this first one, the primary concern is actually to the mom. But regardless, so it's worth knowing that Rogam, I don't know if it's got the same like brand name where you are, but it's the, like when we're talking about blood types, if we're saying someone's like positive or negative, the RH factor is what we're actually looking at. And if we have a RH negative mom who is exposed to RH positive blood, the concern there is she can build up like a isoimmunization against that RH positive sign. So in the future, like if she in the future were to get pregnant again with a RH positive baby, it could spontaneously abort. So we want to avoid that. So we give this immune globulin to RH negative moms who are potentially exposed to RH or who are exposed to RH positive blood to prevent that from happening. So the case that is specific to OB is RH negative mom carries a RH positive blood and something happens during delivery where mom is potentially exposed to baby's blood. So like I'd have to double check this, but I think like the for sure things would be like a C-section. Well, I guess maybe not. I don't know. I have to look that one up. But like if there's a delivery where there's potential, I don't know. I guess I need to look up the specifics of when that would be. Like a vaginal delivery with complications where blood could cross over.
I know in ED, if there's any PV bleeding, we'll give it.
Yeah, I think that, I guess a C-section would probably be contained unless there's some kind of like trauma to the baby. So I think a C-section would be pretty safe, but a vaginal delivery with any bleeding, I think would be a case to give Rogam. And then the other situation that you're probably familiar with is like blood transfusion. So if you have like a woman of childbearing age and we give her positive blood, but she's negative, then Rogam as well. So cool. And the next two are just vaccines that are given after birth. I don't think that the vaccines are like a high yield thing on the NCLEX, but they may ask just in general, like as far as like coming up with a care plan for a baby after delivery, what's something to consider. One of those would be vaccinations. I don't think they would test you specifically on which ones and like timelines and things like that. And then the next two here, I also don't think are super high yield on the NCLEX. But one would be like ophthalmic ointment if we're worried about any infection during delivery, and then vitamin K if we are short on our clotting factors, if there's like some kind of concern for anemia. But I don't think either of those would be particularly high yield. But if they are, it's going to be referred, it's like going to be in the context of like things to do for the baby after delivery. So if you just remember that like that erythromycin ointment and giving vitamin K, like that's the situation, I think you'd probably be able to answer that question just fine. And then some other sections that were mentioned in this textbook I have that I don't think you need to focus on at all would be medications for pain relief during labor. Like that's not something I think knowing your pain medications in general is something that's testable, but I don't know about specific for OB things. And same thing with like anesthetic agents for delivery. Like I don't think they would test on that. And the last one would be like surfactant therapy in the neonate. I think all of those are pretty niche, and the NCLEX is more for like, it's more of a, it is an entry level exam. So they're not looking to get into the nitty gritty detail on that sort of thing.
Yep.
So I don't know if that was useful for you, or if there's any specific questions you have on these. If there's anything you want to dive into a little more.
Could we go over, and only if you've sort of got your head around it, some of the OB sort of emergencies, your placenta previa, placenta abrupta?
Yeah, okay, that's a fair point. So abruption, we'll start there. That's when the where the placenta attaches to the uterus, it starts to tear away. And that can cause bleeding in whatever space is left there. So I think having a visual to see how that one looks is definitely helpful for understanding the physiology there. But things that can cause that to happen, because there's like a lot of small vessels there, like it's quite dense in terms of like microvasculature. Things like hypertension can put you at risk for that, because you can cause that, you can cause those tears to happen or that vasculature to break down. You can also see with trauma. I think the key like diagnostic would be don't yeah I don't think you'd see external bleeding with abruption routinely unless you also like unless it like ruptured somehow or so like normally that bleeding would be contained in that space. Um, if you do see bleeding, I think the textbook way of describing it would be dark red, because it's sat there for a while. Now, in reality, I don't know how often that actually happens, but that's like the
Yep.
textbook description of so like the dark red bleeding, whereas placenta previa, I think they describe that as like bright red bleeding.
Okay.
But in real life, like I don't know how easy it is to make that distinction between the two. Um, I don't know. That's what the books say, I guess. So it's likely to be
Mm-hmm.
testable. And then previa is when you have the placenta attaches to the uterine wall over top of the vaginal opening. So during pregnancy, it's not so much an issue because like everything develops just fine. But as you progress to delivery and you start to dilate in the face, that area opens up, and then you might see that bright red bleeding. Um, I don't know if that description makes sense, but it definitely helps to look at pictures for those two to understand like the difference in the physiology. Um,
Mm-hmm.
so with abruption, you basically have like some kind of tearing away of the placenta from the uterine wall. Um, Kind of like if you were looking at like a balloon like here, and here's like the opening where the baby's coming out, it's somewhere like in the balloon part. Whereas in previa, like this part starts out where my thumbs are, they start out slow. And as it starts to open up, that's when you start to see bleeding.
Mm-hmm.
So um, treatment for those is mostly like supportive and like resuscitation based. So it's not like you're going to do something to prevent either of those processes from happening. Um,
Yep.
in the case of placenta previa, depending on like how, like, I don't know, like if here's your, we're going back to this analogy here, like if this is your opening here where my thumbs are, um, if you're like smack dab in the middle, that baby's likely going to need a C-section or like the bleeding is going to be quite severe and mom may exsanguinate. If it's just like a little bit of overlap, like if I'm implanted here, like just a smidge, I may get some of that bright red bleeding with delivery, and it may be totally fine. So it lives on a spectrum from where it like may be totally okay and it may be quite severe.
Mm-hmm.
And then with abruption, it also depends on like how much blood is released, like
Mm-hmm.
how big that abruption is. Um, Again, this is not like my area of expertise, but I imagine that there are likely some abruptions that are quite small that nobody knows about until after the placenta is delivered. And maybe you see some like, I don't know, like some kind of clot on the placenta, maybe. But I don't know that for sure. That's something that I would have to ask somebody who works in that setting. Uh,
Mm-hmm.
but yeah, those are the two big ones as far as like bleeding goes. The other one, which we talk about more in the ER and transport setting, would be a uterine rupture. And that's yeah, when that uterus, that container that's incubating the fetus, when that gets injured, normally it's like a traumatic injury to mother's belly, like a blunt force trauma or something like that. When it ruptures and all of the fluid contained, like it's no longer able to like maintain its shape. And the telltale sign of that is you're able to palpate fetal parts by palpating the mother's abdomen. So that's
Hmm.
like I don't know, that's the keyword trigger for like the testing setting. Although I'm not sure how often that comes up on the NCLEX, but for sure in like your um, CEN or your, I don't know, CFRN, FPC type thing, that's the telltale sign. Um,
Hmm.
I, I don't know specifics on it, but mortality is quite high for the fetus with a uterine rupture. Um, and like that will likely have to be a C-section delivery to salvage that situation.
Yep.
I mean, I guess there's a, yeah, yeah, I can't, I guess I was going to say maybe there's a case where, I don't know, mom and dad are like on the way to the hospital after mom's water broke and they get in a car wreck and I have a uterine rupture and maybe the baby can be delivered, but that wouldn't happen because you need the contractions, right? You need the force of that uterus pushing the baby out. So that's for sure going to have to be a C-section. So
Yep.
I just had to explain that one out loud to myself, I think.
I do the same thing.
Um, so I think those are the three big ones, I guess, leading up to delivery. The other big complication would be postpartum hemorrhage. Again, that's not something I think that comes up often on the NCLEX, but for sure comes up on those other exams. So our main treatments there are resuscitation um, with like a couple extra things. So we can do all the things, you know, like we're getting away from fluid resuscitation. So blood would be ideal. You can give TXA in these situations. Oxytocin to help force that uterus to contract, combined with doing a fundal massage. Um, like in a testing environment, you just have to know like fundal massage, and that's all
Hmm.
they're looking for. In a practical setting, just know that it's like quite an aggressive thing. So you have to get in there and put quite a lot of effort into that. It's not just like putting your hand on the belly and like, you know, giving it like a Buddha belly rub. Um,
Hmm.
it's quite an aggressive thing. Um, the
Yeah,
other
it's
thing
quite a
that,
way in too, isn't it? I was surprised how far you've really got to push in to
yeah,
find it.
for sure. The other thing that sometimes comes up, and this is one of those things that I have no idea how often this actually happens in practice, is you sometimes will hear reference to people like putting something inside and like using that as
Yeah.
like to fill that space inside the uterus and then like fundal massaging around it to kind of pack
Right,
it
then
around
you're
and leaving
compression.
that, yeah, like leaving that in there. Um, I've heard it mentioned in like pre-hospitally and like emergently that you can like do that with a fist and someone just like rides the receiving facility with their like fist inside.
Yeah.
Um, I've also seen it in classes where people mention um, using a Foley and like inflating the balloon like in excess so it's quite big. So putting the Foley in and then inflating it and then doing your fundal massage around that. That said, that's one of those things that like I don't actually know how often that actually happens. I have a feeling that like it's quite rare, but I don't know. Like maybe it's one of those like last ditch efforts if you're like
Mm.
in a rural setting and you don't know what to do. But
Yeah, if you
that's,
don't have a surgeon nearby
yeah,
to
for
do the
sure. Like I
diagnosis,
could,
you've got to do that until you can get to surgery.
yeah. Yeah, the first time I came across that, there's a series of courses called like the one for babies is called Helping Babies Breathe, and the one for mothers is called Helping Mothers Survive. Um, I think it's I think it was put together by the same group that does like neonatal resuscitation program. But these courses are designed to teach in the developing world. Like the Helping Babies Breathe one
Mm.
is geared to people who like work in a healthcare setting, but like may not be like licensed or whatever. They like, you know, maybe they're like working in like a delivery and like a mom baby unit and they just like help do deliveries and smack the baby and wake them up. Um,
Mhm.
but it was like to teach basic resuscitation. So like a BLS version, I guess you could describe it as, of neonatal resuscitation, and then they have a subsequent class that's for same idea, but for helping mothers survive. And that's why I first come across it. And I've since seen it in like in other courses, but again, like I think that is in reality likely reserved for those types of settings or somewhere where it's
Mm.
last year.
Yeah, I came across, I did a rural and remote for those that are way out in the middle of nowhere without a doctor and dealing with it on their own. And yeah, they said it. And my sister's a midwife. She said she's done it a couple of times in
Okay.
some more rural hospitals where they've got to
Yeah.
call in the surgeons. So yeah, by manual compression while they sit and wait for the surgeon to finish his golf game and get to the hospital.
Yeah, that's fair. So she's doing
So
it
pretty,
like with a hand. So yeah, I think
yeah.
that's far more common. The Foley thing, I'm not sure about that one.
Yeah, I hadn't heard of that one
Yeah.
before.
So, um, cool. So
Pretty
just
crazy
to,
though.
yeah, that'd be nuts. But I mean, I guess, I mean, it's same idea with like you're like in a trauma center. If you have like a gnarly trauma come in where you have something like in the box, you're gonna crack the chest and just put a Foley in any hole. So I don't know.
Mm-hmm.
They're versatile tools. It's worth keeping in your bag, I suppose.
Yep.
Um, okay, so postpartum hemorrhage, we can do all our normal resuscitation things plus oxytocin, um, and fundal massage, and maybe do like bimanual compression or the Foley trick. Um, yeah, I think the only other thing that sometimes comes up along those lines is if mom is able to breastfeed, that can stimulate some endogenous release of oxytocin. But that said, I think if you had like a genuine resuscitation that you're working on a postpartum mom, that's probably not something that we would take the time to do, but like it comes up in a testing environment. So
Mm-hmm.
just be aware of that. Um, yeah, one other thing that's more of like a discussion is I know the way we typically teach giving oxytocin is you can either give it as an IM dose or you can put it in a liter bag and give it slowly. Um,
Mm-hmm.
but that said, like I'm not entirely sure the reasoning behind giving it IV slowly. Like I don't know enough to say for sure like why we don't just give the IV push dose as a push. And
Yep.
I've seen it done before in like a really bad like postpartum hemorrhage um, by another provider, and like I don't know, it seemed to work. Like mom survived,
Mm-hmm.
but I don't know why we teach to give it either IM or IV over time versus just giving it IV directly. That might be something that I can, yeah, I'll have to look that one up, and I'll send you a follow-up email or something.
Mm.
Um, but all those details, I don't. That's not stuff that I think would come up on the NCLEX for sure.
Yep.
Um, yeah, I think that's. Let me think. So we talked about abruption, placenta previa, uterine rupture, postpartum hemorrhage. The other emergency would be eclampsia, and we talked about that a little bit earlier. So our fix for that would be to give magnesium sulfate. We don't want to slam it. We don't want to give it fast, but we can, drip it in over 10 minutes.
Mm-hmm.
And then our concern when we give mag sulfate is that we can cause respiratory depression. So the textbook or the test will want you to say that we're checking for deep tendon reflexes. In reality, in most settings, I think we're just assessing like a waveform capnography. And if we see evidence of respiratory depression, then we can make decisions then. And then
Mm-hmm.
if we gave way too much and the patient stops breathing, the fix for that would be calcium.
Yep.
The other emergent things that I think maybe do come up on the NCLEX, and I think I had a couple notes on that previous list, would be like preterm labor. So it's not necessarily like always an emergency, but if you have a situation where you want to delay the delivery of the baby for whatever reason, let's say you're in a small hospital and you want to get them to a big hospital, or we're in the field and we want to get them there, or the baby's like preterm, then yeah, the medications for that would be the class we refer to as tocolytics. So terbutaline is like the most common one. We can also use mag sulfate. Yeah, I think those are the two that generally come up on testing. There's a couple other on
Hmm.
that list that are used more, I think, in a hospital setting, but like in the field or like emergently, like those are the two we'd use. Um, yeah, Torbedoling and Mac. And I think that's all the emergency things. Um, the other thing that doesn't really matter so much for the NCLEX that is like worth looking up. Hold on, give me a second to. I'm gonna pull this up and screen share it with you. See if I can find it. Okay, so let me share my screen again with you, and we'll pull this up. Can you see it there?
Yep.
Okay, so this is a book, a textbook that you can just find for free online, and I'll send you a link to it as well. But this program is called the Alarm International Program, uh,
Hmm.
and they have this mnemonic for dealing with like complicated delivery. And let me just scroll down and we'll pull it up here. Uh, okay, so this is the mnemonic here. And we don't have to like read every step, but it's basically like a way, like if you had a baby who you're trying to deliver and it's not delivering, like things you can do to help facilitate that delivery. Like in reality, like if I tomorrow at work, when I go back on shift, if I had a complicated delivery, like in the middle of nowhere, like New Mexico or West Texas, and I had to like
Hmm.
deal with some kind of like complicated delivery, like this is something that like I don't have memorized. I've never worked in this setting, but I always keep on me like I'll send you a reference card actually. I'll send you a link to this and also like the reference card that I use that
Hmm.
has this mnemonic and pictures of all of these maneuvers so that like
Yep.
in that setting, I can just pull it out and put it right next to us and we'll just work through them one at a time. Some of the things like you probably don't have the autonomy to do in most clinical settings, like you and I, like doing an episiotomy. But this mnemonic was um, designed to be universal for all providers. Um,
Hmm.
so we don't have to like go over like all the specifics of this, but like this textbook is awesome. It was just like available for free online. There's pictures of all of the maneuvers as well as discussions. Um, these things aren't tested on the NCLEX, but some of these maneuvers do come up on your FPC and CFRN type tests. Like if you're interested in getting into transport whenever you do get over here to the US. Um,
Hmm.
so a lot of these maneuvers do come up. So this is an awesome reference for just like reviewing that kind of stuff before you go into a testing environment. And like I said, I parsed out all these images and kind of made a little quick reference guide that I carry on me at work. Um,
Hmm.
but yeah, that's the other complication you may come across in like OB would be like a complicated delivery. That said, I
Yep.
don't think this is something you'd see on the NCLEX, but it's just, yeah, it's good to know. And I think just knowing where to find a reference like that is super important because um, in the absence of like time working in that setting, I don't think it's
Mm.
realistic to expect that most of us would be able to perform those kind of things without some kind of reference. So just
You just don't see enough emergencies, do you? Even if you've done a
yeah,
bit of training
yeah,
in
and
delivering.
yeah, realistically, like I mean, like humans and all mammals in general have been like giving birth for thousands of years, and they almost always go just fine. So the incidence of like some kind of difficulty with delivery is quite rare. And then the incidence of a delivery that's complicated where they didn't know about it ahead of time and like made plans to accommodate that are even
Mm.
rarer. I think
Yep.
it's different if you're working, like in a
In
totally different
Africa or
setting.
something. Yeah.
Yeah, like, but in general, like, yeah, the chances of us seeing that sort of thing with the frequency to build some level of like confidence in those skills is just it's not going to happen unless you take time to go specifically work in that field. So yeah, having access to those references I think is super good.
Mm.
Um, Okay, so let's just do a quick mental review of the complications just to make sure we got them all. So we talked about um, abruption, placenta previa, uterine rupture, postpartum hemorrhage, eclampsia, and we also just alluded to the idea of like that it lives on a spectrum with pregnancy-induced hypertension all the way up to HELLP syndrome, and then complications of delivery. I think that's, yeah, I think that's most everything.
Mm-hmm.
Yeah, I don't know, am I missing anything?
No, that's sort of my mental run through that I've been working with. That seems to be the big ones.
Yeah,
Then you like to say there's some general pre and post care stuff, but that's not too bad. That's sort of general nursing. I can deal with that.
right. Yeah, and I was actually looking before we got on the call, like some tests do offer outlines like for like specific testable items. And there is stuff for the NCLEX, but it's not that detailed.
Mm-hmm.
Whereas like for our certification tests, like, two we talk about all the time here in our setting is the CFRN, like your flight nurse one, and then your FPC, your flight paramedic one. Those ones have like
Mm-hmm.
pretty good outlines of like specific things that they're going to test on. And there's all kinds of like materials specific to that. In the nursing side, like for the NCLEX specifically, a lot of that stuff lives behind a paywall. So it's like proprietary stuff.
Mm-hmm.
That said, you've already purchased a review book, so they likely have an outline. If it's not like in your book itself, it like maybe on their like online content.
Yep.
And they might have a little better guidance than I do about specific things that may or may not be tested on. Um,
Mm.
so even if it doesn't come direct from like NCLEX itself, um, like all these testing agencies, they build their review material built on like all kinds of feedback over years and years and years of this with like lots and lots of students. Um,
Mm-hmm.
so even if it's not like officially sanctioned, I think it's pretty good. Um,
Yep.
so yeah, as far as like figuring out like from the stuff we talked about and what's on that list, what is for sure testable and what's not, like I would have to like defer you to someone else on that.
Yep. No, that's okay. Any other sort of common meds and interaction type stuff you think is the high points?
Yeah, I know they're not super big on doses. Um, I vaguely remember getting some questions on like interactions and like when meds should be administered, but I don't
Mm-hmm.
think, I don't know, maybe that's like a holdover memory from when I like missed all those questions in pharmacology
Yeah.
when I was in nursing school. Like I don't, it seems weird to me, like thinking back on it, that those would be tested on the NCLEX because they have so many other things that are more important. Um, so yeah, I think probably your best bet if you're like for time spent would be if you have a review book that just has banks of questions, just to focus on that. Uh,
Mm-hmm.
especially if they have like little short narratives about like, why you got the question wrong. Um,
Yeah, and they
would kind of,
do, which is good.
yeah, I think that kind of prep is quite high yield for like the time spent on it. Uh,
Mm-hmm.
yeah, I wouldn't take the time to like make note cards for all the drugs you can think of or all the drugs that come up in your like pharmacology book from nursing school, because I think that just takes a lot of time and takes away from things that are probably more high yield on the test. So I think the best
Mm-hmm.
strategy would be to focus on questions, and then during those questions, if you notice a medication come up, um, maybe just like pull out a drug reference guide and look up like just quiz yourself for the next couple of days on like drug class mechanism indications and any like significant complications or drug interactions.
Mm-hmm.
But I don't think you need to get into heavy detail on any of those.
Yep.
Yeah.
Awesome.
Sweet, man.
Well, thanks very much for that. That was really helpful.
Yeah, for sure. um yeah, I can send you a copy of this video whenever it saves, and I'll send
Mm-hmm.
that a link to that. I had that paper that I talked about like pregnancy-induced hypertension and different treatments,
Yep.
and then this reference for that alarm mnemonic and also like the little reference card that I made and use.
Mhm.
So yeah, I'll send that stuff your way. And then, yeah, if you have any questions, let me know.
Yep.
If you make it to Colorado and decide you want to live somewhere with less people, New Mexico, Mexico is always recruiting.
Yeah. I've been there before. My wife's good friends from Albuquerque, so I've been down there and get down there every once in a while.
Right now.
Yeah, I was pretty amazed how different it is from Colorado, and it's really
Yeah,
not that far away.
yeah, it's super close. I mean, Colorado's awesome. This whole region is awesome.
Mm,
Everything in the Southwest. Yeah, I think I'm a lifer. So
yeah, I just love being so near the mountains in Denver there, and just being able to look up and see them all the
yeah, for
time.
sure. Yep. Well, right on, man. Yeah, let us know if you ever have any other questions or want to review, and do let us know how the NCLEX goes.
Yeah, I will. Thank you very much for that. I really appreciate it. It's been very helpful.
Awesome. All right, dude. We'll take
And
care.
I'll let you know.
All right.
Thanks.
Cool.
See ya.